Heart Disease, CHF Hospice Eligibility Medicare LCD.
Heart disease, CHF hospice eligibility under the Medicare LCD focuses on patients with end-stage cardiac disease who exhibit NYHA Class 4 symptoms, meaning they experience dyspnea, fatigue, or chest pain even at rest and are unable to perform minimal physical activity. Eligibility is supported when symptoms persist despite optimal medical therapy, such as diuretics, vasodilators, and ACE-I or hydralazine with nitrates, or when the patient has angina at rest that is unresponsive to nitrates. Patients must also either not be candidates for further cardiac procedures or have declined them. Case studies within this training illustrate how these criteria appear in real-world clinical scenarios to guide accurate hospice referrals for Parrish health systems.
The purpose of this training is to build a strong understanding of Medicare LCD criteria for end-stage heart disease, highlight the key clinical indicators that support hospice eligibility, and strengthen documentation practices to ensure accurate and compliant referrals. Through real-world case examples, the training equips providers with the insight needed to recognize when patients meet hospice criteria and confidently guide them toward appropriate care. End-stage heart disease is characterized by chronic, progressive cardiac decline in which patients continue to experience significant symptoms despite optimal medical therapy. As the disease advances, functional abilities diminish, daily activities become increasingly difficult, and patients often require frequent hospitalizations or emergency room visits. These ongoing challenges contribute to a reduced quality of life and place a growing burden on caregivers, underscoring the need for timely recognition of hospice eligibility. The core eligibility requirement centers on NYHA Class 4 symptoms, meaning patients experience symptoms even at rest and are unable to perform minimal physical activity. These individuals typically have dyspnea, fatigue, or angina with any exertion and demonstrate marked functional impairment despite appropriate medical treatment, indicating advanced cardiac decline consistent with hospice eligibility. Optimal medical management requires that patients continue to experience symptoms despite appropriate therapy, including the use of diuretics, vasodilators, ACE inhibitors or ARBs, hydralazine with nitrates, beta blockers when tolerated, and antiarrhythmic medications when indicated. Many patients may also require supplemental oxygen as their disease progresses. Persistent symptoms despite this comprehensive regimen support eligibility for hospice in the setting of end-stage heart disease. Hospice eligibility also requires that no further cardiac interventions are available, meaning the patient is either not a candidate for additional procedures or has chosen to decline them. This may include advanced interventions such as CABG, PCI or stenting, valve replacement, or upgrades to devices like ICDs or pacemakers. When these options are no longer appropriate or desired, and the patient continues to decline, it supports classification as end-stage heart disease. Supporting clinical indicators that strengthen hospice eligibility, though not required, include an ejection fraction of 20% or less, treatment-resistant dysrhythmias, and episodes of cardiac-related syncope. Additional findings such as a history of cardiac arrest or resuscitation, a cerebrovascular accident caused by cardiac embolism, or the presence of concomitant HIV disease further demonstrate advanced cardiac decline and help substantiate the overall clinical picture of end-stage heart disease. Functional and nutritional decline in end-stage heart disease often presents as progressive weight loss, diminishing ability to perform activities of daily living, increasing fatigue, and a consistently poor appetite. As patients weaken, they become increasingly dependent on caregivers for basic needs, and many experience limited mobility or become fully bedbound. These indicators collectively reinforce the severity of disease progression and support hospice eligibility when aligned with the broader clinical picture. Frequent hospitalizations are a common pattern in end-stage heart disease, often reflected by 2 or more CHF exacerbations within 6 months, repeated emergency room visits for dyspnea or chest pain, and recurrent episodes of fluid overload. Patients may show a poor response to diuretics over time, and many experience worsening renal function as cardiac output declines. Together, these recurring events signal advancing disease and help substantiate hospice eligibility when aligned with the overall clinical picture. Key documentation requirements for hospice eligibility in end-stage heart disease include listing all specific cardiac medications with their doses, describing the patient's functional limitations despite therapy, and incorporating recent diagnostic findings such as echocardiogram or cardiac catheterization results. Documentation should also explain why the patient is not a candidate for further cardiac procedures and clearly record the patient's informed decision if they have declined additional interventions. Finally, noting symptom progression over time helps establish the overall trajectory of decline and supports accurate eligibility determination. This case involves a 76-year-old male with end-stage ischemic cardiomyopathy and congestive heart failure, presenting with dyspnea at rest, fatigue, and orthopnea, and an ejection fraction of 15%. His recent history includes 3 CHF admissions within 4 months, and despite maximal medical therapy, he has shown a poor clinical response. The patient has declined further cardiac interventions, and based on his advanced symptoms, repeated hospitalizations, severely reduced EF, and lack of additional treatment options, he meets Medicare LCD criteria for hospice eligibility. This patient qualifies for hospice based on clear NYHA Class 4 symptoms, persistent limitations despite optimal medical therapy, and an ejection fraction below 20%. His multiple recent hospitalizations further demonstrate disease progression, and he is no longer a candidate for additional cardiac procedures. Combined with notable functional decline and increasing dependence on caregivers, these factors collectively meet Medicare LCD criteria for end-stage heart disease. Here is your content rewritten as a clear, cohesive paragraph. Common documentation errors to avoid include failing to provide a complete medication list, omitting a description of the patient's functional status, and not explaining why further cardiac procedures are not possible. Notes should clearly show symptom progression and provide evidence of clinical decline. Without these elements, documentation becomes vague, incomplete, and insufficient to support hospice eligibility. Hospice eligibility for end-stage heart disease is determined by the full clinical picture, emphasizing the patient's symptoms, functional decline, and overall disease trajectory rather than relying on ejection fraction alone. Strong documentation should clearly outline why the patient is considered end-stage, including detailed descriptions of functional limitations, treatment history, medication response, and the pattern of symptom progression over time. Capturing these elements not only supports accurate eligibility determination but also paints a complete narrative of the patient's decline. Hospice care plays a vital role in supporting both patients and their families as they navigate the challenges of advanced cardiac disease, offering comfort-focused interventions, emotional support, and guidance during a difficult stage of illness. Early referrals allow patients to benefit from these services sooner, improving stability, reducing crisis-driven hospitalizations, and enhancing overall quality of life for everyone involved.